Common issues I see in immediate placement of a dental implant. We have our extraction socket here. We've got our gingiva, and then we've got our medullary bone and the cortical plate that runs around the confines of our alveolar bone, and then around the extraction socket we've also got cortical bone. So the tooth is removed and we go to make an immediate placement of an implant. If we follow the socket of the tooth, we're going to run into a couple problems. One is often, especially in the maxilla anterior, if we follow the position of the root and make our osteotomy there, we're going to fenestrate because the roots naturally sit very close to the buccal bone, and our implant position to try to be within good healthy bone and in the safe zone, we're going to require to be lingually tilted. So when we go to place our implant, I like to use a pointed lance drill first, make my purchase all the way through the cortical plate, and once I have that, then I'll move to my 2mm twist drill, pilot drill, follow the same trajectory, and then take my drill and upright it to head it to my angle, which needs to be a compromise of being within good bone and also having good prosthetic positioning that's not going to leave us with an unrestorable trajectory that is too facial. So that's the first mistake we see is the positioning as far as leading fenestration, and that's often an issue when someone either is afraid to flap or they decide not to flap for another reason that we're about to talk about. So the second problem I see with immediate placement is being too aggressive with lane flaps. So one thing we know about the anatomy around our extraction socket is that blood supply is incredibly important to the healing and stability of our system. So we need to respect the biology when we place the implant so that the healing looks good on day one of restoring the implant and also on later recall cycles years down the road. So to do that, we need to understand the biology. Within the bone, we've got a lot of blood supply in the medullary bone, but we have about 2mm cortical bone around the confines that is less vascular. And we know that the blood supply to all the bone comes either from the medullary bone here, or it comes in the periosteum that sits inside of our soft tissue, or it comes from the PDL when there's a tooth. So those are the sources of blood supply. So when we extract the tooth, we're going to lose one source of blood supply, which is the PDL. We know that. So if we lose this source of blood supply and we also flap, we've now taken virtually all of the blood supply away from this bundle bone, the thin bundle bone on the buccal. So this is the buccal or the facial surface, and this would be the palatal surface. So because we don't have that medullary bone, just due to the thinness of this bundle bone, when we lose both blood supplies, we'll get a lot of bone dieback. So on immediate cases, I always try to avoid flapping at all costs for that reason. Now, if there's already a defect in place and we're doing major grafting, then that's a different story. But that would be the second common error that I see. The third error is wanting to take a tooth out and just place an implant. And this seems easy and straightforward, but we'll discuss the issue with that. So say I take my tooth out and decide to just drill to the length of the existing socket, and I place an implant here. We know it's going to be slightly larger than our existing socket to get that primary stability, but we place a nice big implant in the socket, and everything looks good on day one. When we go to restore, we notice that we've lost now our bone back to here, and all this bone has disappeared. And the gums now have receded to match that. So why did this happen? Again, we know that we are deficient on blood supply here. We know also from the studies that we should plan to lose some amount of bone during the remodeling process. But we know that if we leave a buccal gap, so if our implant only came to here, and we have a space, and we graft that space, we know that minimizes the amount of bone dieback. So the recommendation here is to place our implant 2 millimeters below the existing crest and leave the buccal gap and graft that gap. By doing all three of those, we'll ensure a much higher likelihood of success in the situation, because when we place a wide implant and we put pressure on this buccal plate to try to gain primary stability, what we're doing is we're crushing the little bit of blood supply that remains. We're putting too much strain on the system, and when bone loses blood supply, it dies and it disappears. So those are three common things that we see in immediate placement. Hopefully this is helpful.